Welcome back to Ohio Counseling Conversations, the official podcast of the Ohio Counseling Association, bringing you updates and conversations from around the state. On today's episode, we're joined by Hayle Fisher. Hayle has worked in hospital settings, private practice, and is currently the Director of Adolescent Services at Premier Behavioral Health Services. Hayle is passionate about providing DBT services to adolescents, young adults, and their families. She currently facilitates an adolescent DBT-IOP group and also provides skill support training to parents. Her clinical interests include working with clients coping with suicidal ideation, self-harm, depression, anxiety, oppositional defiant disorder, and borderline personality disorder. Hayle is also passionate about leadership and advocacy, as evidenced by her position as president for the Ohio Association for Specialists in Group Work and her enthusiasm for presenting at conferences. And as always, I'm your host today, Dr. Marisa Cargill, a counselor at Cuyahoga Community College in Cleveland, Ohio, and counselor educator at the University of Akron. Thanks for tuning in. We're glad you're here. Well, welcome back to Ohio Counseling Conversations. We are here with Hayle Fisher today. Welcome, Hayle. We're so happy you've joined us to talk about our topic today. And before we get into that, please just tell us a little bit about yourself and your experience.
Absolutely, and so happy to be here today. My full name, Hayle Fisher. I'm a licensed professional clinical counselor, and I also have my BC-TMH. That stands for a board certified telemental health counselor. I am currently the Director of Adolescent Services at a private practice and mentor called Premier Behavioral Health Services, and we are a full DBT or dialectical behavior therapy practice. So we do all the different parts, including intensive outpatient programs, individual counseling, those weekly treatment team meetings, and just all the different parts that do come with DBT. The populations I typically work with are adolescents and their families, just since when we're treating adolescents, it's typically not just the teen, but it's the whole family system that comes with it. So I also lead our parent in IOPs, but I also co-facilitate our adolescent intensive outpatient program. So again, I work in the individual capacity, but also in group settings. As a little bit of a fun fact, I also am the president of the Ohio Association for Specialists in Group Work. So you may often see me engaging in group type of aspects all over the place.
Very nice. So not necessarily a lot of free time, it sounds like. You sound like a busy person.
Perhaps. Definitely. And some of that's just, how it goes in the field.
That's okay.
But I also think there's a huge
good busy. So
good busy.
Group work seems to be a common theme here, I'm hearing. And this is a specific population that I'm hearing as well. So tell us a little bit more, what made you want to become a counselor, and then maybe speak to what led you to those specific modalities and population as well.
Yeah, I always love that question as far as what made you want to become a counselor. And I mean, as far as with my answer and everything, I think some of it is just based on my own personality and such. I've always really loved listening to other individuals' stories and really hearing about other individuals. That's something I think I just realized early on, even middle school, like, wow, I could listen to people's stories all day or just really get to understand them, what kind of contributes just to what makes them them. And kind of evolved from there. And I also think this is not necessarily the easiest field to be in. I mean, when we are sitting with clients all day and holding space and energy for their emotions or some of the biggest traumas they've experienced and such, it's hard work. And I think some of that was also recognizing the ability to navigate those types of things. It requires a lot of boundaries. And so I think it was that combination of having the boundaries to navigate that, but also the interest in hearing stories, understanding individuals, and also I think social justice is a big part of my value system overall, and all of that kind of comes together to work in the micro level as far as a counselor, but also believe in macro level and just everything else as far as those bigger system changes too. So that's how I kind of professionally identify within the field.
Well, that's awesome. I like the origin story, but also how it links to a lot of your values today as well. That's really, really powerful. And so tell us again more, like, how did this all end up into this like specific population in working with adolescents, and then then get married with a lot of group work.
Yeah. And again, just kind of with that, I've wanted to be a counselor for a while, and I think I'm one of those very fortunate people where you choose a career in middle school, high school, but it actually really worked out as far as really feeling rewarded by this type of field and rewarded by the value system that comes with counseling and everything. However, the one thing that did change is what I always wanted to work with specifically was children, and so younger individuals. And I had a couple clinical experiences working with kids, and I did okay, and I liked it, but I really felt myself grow into the role and really grow into my professional identity once I started working with adolescents. And some of that was just based on practicum placements and luck and everything that came with it. But also, again, having those diverse experiences and working in a hospital setting versus working in, private practice, but also the IOPs and everything. Sometimes got to experiment, have some diverse experiences to really find your niche and what works with you. And the DBT part, I know I really like the parts of DBT, and I'm sure I'll talk about that later, but just the dialectics that comes with it, finding the balances, it's that structure but authenticity. When we have both of those together, I think that's really powerful, and why I specifically navigated towards DBT, and just also, again, the setting I work in anyways.
Very cool. Yeah, so being open to some of those learning experiences when you were in your earlier stages led you maybe down a different path than you originally thought, but found like a really rewarding experience for yourself.
Absolutely.
Love that. I think you're not alone in that. I can relate to that experience, but I feel like as I talk to students, as a counselor educator, and other colleagues, that I hear that theme sometimes happens to a lot of us. So definitely not alone. Now, we're really proud of you, Hayle. As a Ohio counselor, we've seen your name, highlighted and featured in Counseling Today, the ACA publication, recently, a few times in the past year, and one of the recent issues highlighted this topic of de-escalating conflict between teenagers and parents. And in that article, I'm just wondering if you could briefly summarize some of those really important takeaways for our listeners from that article.
Absolutely. And this is going to look a lot of different ways as far as conflict that does occur between teenagers and their parents. I mean, some of that obviously, yes, but also just based on the presenting concern, because each, of course, family dynamic is so different and unique to themselves. So, I mean, this could exist anywhere from teenagers presenting with oppositional defiant disorder to depression to a lot of high-risk behaviors that have gone on, whether it be substance use or self-harm actions or some really traumatic, just ongoing and continuous challenges. So some of the things, especially working in this population, especially doing the intensive outpatient programs, it comes up pretty frequently. And I am a big, big believer as far as incorporating parents in. Again, we always have to treat things dialectically, as in each case is going to be unique, and sometimes there are exceptions to that. But research has continuously shown that outcomes are the best for the teens receiving therapy when parents have some sort of involvement in the treatment as well. So that's what I really like about our intensive outpatient program, is we have a family group that also comes with it. But even again, if it's not even working in a group or a very structured higher level of care, also trying to incorporate it individual counseling sessions too. Again, I could talk about this all day, but as far as with it, I think one of the biggest aspects is training parents with the skills too, or also giving them the same resources. And I know that's what I talk to teens a lot about, is how do we regulate our emotions? How do we survive distressful experiences? How do we identify what we're feeling and where is it in our body? At the same time, just because they're teens, yeah, they struggle with it, but so do we as adults. So do I as a human. Those are hard skills.
Yes. If the teen is having trouble mastering it, it might be because the parents weren't able, to teach those skills because they didn't learn them themselves from their parents. And so the system needs to learn the skill, or skills rather.
Correct. Absolutely. Okay. A large aspect of what I explore with parents is what we call dialectical dilemmas. So in DBT, just a super quick overview, dialectics is the idea that two opposites can both exist simultaneously. And when we accept both of those opposites as equally valid, we can synthesize a new truth and create a new way of viewing the situation moving forward. So a big one that comes up with DBT is acceptance and change. So I can accept myself exactly as I am, and I can also advocate for change. Because if I am just accepting things without change, things stay the same, and that's when we feel trapped or we feel stuck or really hopeless or kind of down on ourselves. However, if we're advocating for change without acceptance, that's when we're putting unrealistic demands on the situation. So if I end up late to work one day, for example, and I said, well, I should have been on time. Well, I wasn't on time. Maybe I was really tired or had pretty overworked and pretty burned out. And if I'm not recognizing and validating those challenges that come up, I'm just placing a bunch of unrealistic expectations. So that's an example specifically, but kind of putting this back in the context of working with parents. I think a lot of times it's utilizing, again, those dialectical dilemmas. So that's where we're trying to find the balance of where am I trying to accept myself and we're not advocating for enough change, or trying to advocate for too much change without the acceptance, and really kind of giving them some of those skills and tools. However, though, on the other side of it, we have a couple different parenting dialectical dilemmas that specifically come up. So the first one is excessive leniency versus authoritarian control, or in less clinical terms, where we're being too permeable with boundaries versus way too strict. Because especially in these systems where there's a lot of disarray or conflict between the parents or teens, what typically ends up happening is, first of all, a chaotic situation. What do we do to chaos? We either put really heavy boundaries down, or we say, it's too much, I need a break, and we step out. But then when we step out, things get even more chaotic to the, oh crap, I have to get back involved, and we try to put all these boundaries, but then it becomes all this pressure on us to constantly micromanage every part of the situation in a way that's not sustainable, until we get burnt out again, and then we're like, all right, whatever, like, figure it out on your own, you've got it, I'm done, until wash, rinse, repeat. So a lot of times it's giving parents the education of, where are you in that? Do you feel like you're constantly trying to overcorrect and flip-flop to the opposite extreme? And so I think sometimes it's the mindfulness of, where am I at the extremes? What is a good balance for me, whether it's 50-50 or 60-40 or so on and so forth, but really trying to give them the education and talk about how do we set boundaries and what does it look like to set boundaries that are reasonable enough to continuously maintain. So that's the big first one that comes up.
Mm-hmm. How do we strike and find that balance?
It's hard.
In systems that have had lack of those boundaries and need to change, because they wouldn't be, seeking support right now if change maybe wasn't needed at this point. There's a lot of I would say issues that come up in working with adolescents, right? And as a counselor educator, this next question I have for you, I feel like comes up a lot in my classes rather, all the time. What do we do about this? What do we do about this? And it's one of those gray areas. And I was happy to read about this. This is in one of the other Counseling Today articles where you discussed confidentiality with adolescents. And so just wanting to follow up to that, could you speak more to that sensitive balance there and issues with confidentiality in adolescents?
Absolutely. And I'm also teaching a crisis intervention, prevention, and ethics class this semester. And I know you definitely agree with what you said, is it's continuously a concern that comes up, especially for counselor trainees or honestly anyone throughout their experience, because it's hard. Because we have some legal obligations. I mean, those limitations of confidentiality, and parents have to give consent for treatment and changes to the treatment plan. At the same time, in our ethics code, we want to give the teen or the adolescent or just minor as much autonomy over the situation as possible, while also recognizing that developmental concern that comes with it and difficulties with always making the best decisions. And that's a hard line to find. I think with it, what really helps here is that feminist approach of collaboration and really including the client in as much as possible and maintaining boundaries where we have to. I know a lot of times when a client comes and tells me that they've engaged in self-harm or they're having some pretty significant suicidal thoughts, it's first of all, where is it where we have to get involved? And I think a lot of times it's that if this is really continuing to the point where, okay, we're not making progress or things are escalating, or especially if they're escalating quickly, I mean, if they have an active plan, active intent, I mean, those are immediate safety risks and safety concerns where we do have to take action. But also sometimes where even if it's chronic and it's low level, but things aren't necessarily changing or maintaining, that is maybe evidence that we do need a higher level of care. What we're doing isn't working. And again, parents have to consent to treatment plan changes.
Right.
So it's that aspect of when we have these conversations with teens, I think it's incredibly, incredibly important to be as validating as possible. And we are kind of we literally are taking away a large aspect of autonomy that comes with it. And that's overwhelming, especially when you're 13 years old. I mean, that's a scary situation, especially when you're at the mercy of the environment around you. And at the same time, again, like it's our ethical and legal aspect to protect and make sure they're safe. So a lot of times what these conversations might look like is, hey, I definitely understand, like, we're going through a lot right now, and I can imagine how hard it's been for you. I really do think it'd be beneficial to bring mom or dad or the guardian into the conversation at this point so we can navigate it together, but also so I can make sure that you're safe. However, what comes up for you as I tell you this, and giving them a chance to process, be angry, that's okay. To be upset, to be scared, and also to give reasons and why that might not be a good idea. Again, we do have some legal aspects, but sometimes there are genuine safety concerns, as in I'm fearful that if I tell mom and dad it's going to escalate abuse at home. And then, okay, there's some information, and maybe, again, we need some other services involved here too, for what it's worth. But we want to give them equal space to also express why they think it shouldn't happen, and kind of evaluating the pros and cons, because again, that's the collaborative approach. We have to maintain certain boundaries, but we have to maintain collaboration.
Right. So it's an important conversation. It's not like us asserting power, making sure it is like we're a team here. We're going to sort this out together and really figure it out as a team. What we do next.
Yeah, it's something I really like to do, is giving them as much choice as far as how it occurs within boundaries and limitations, so kind of that forced choice for what it's worth. But a lot of times I'll say, here's what I plan on saying to mom and dad. What would you like to edit about this? And I mean, to a certain extent, again, there are some things like, this is a part that I do have to maintain. However, is there a different way to express it, again, within some parameters? The other part of what I like to do is giving them a choice of how the disclosure occurs. Like, would you like me to tell mom and dad, or would you like to tell mom and dad? And if you'd like me to tell mom and dad, would you like to be there, or would you like me to have that conversation individually? And if they want to tell mom and dad, or again, a guardian, do they want me to be there, or do they want to do it individually? And again, if the situation is, we're not in active crisis, we're safe enough, and they're, again, not those immediate safety concerns that need attended to, sometimes I will say, okay, so I'm going to let you go home tonight, have that conversation, and we'll call mom at 9 a.m. tomorrow, and we'll talk and just kind of confirm. But my job here is also to give mom some coaching and skills on what you need in these moments. And so is there anything that you would like mom to know about what your needs are, how you'd like to see this navigated and everything? So the goal of this is really to reinforce them advocating for themselves. Because again, if they're going home and telling these conversations to their parents, that's them taking accountability and also taking that autonomy to have these conversations. Again, with certain parameters, but that's what we really want to promote at the end of the day, is the parents and teens feeling comfortable enough to come together and have uncomfortable conversations.
Right. And so how could mom and dad better respond if you bring this to them? I can advocate for you in that conversation as well. So I really appreciate everything that you're saying there. So while it's collaborative and there's a team approach, like, we recognize we still have all of those professional responsibilities and legal obligations, but we're going to still try and maintain that the client has some autonomy, because that's really important, and that they are empowered to the degree we can allow it, right? To those boundaries that we can take them to within the law. So that's, I think, so helpful. And how have you seen that play out for you, like with clients? Like, what outcomes do you see when that plays out?
Yeah, it really depends. Of course, each case is specific and individual to its own. Typically, my biggest thing is de-escalation, because I think if we immediately take that hard stance of just extreme emergency, I mean, that also can punish, as far as when I speak out, everything goes to emergency crisis reaction mode, and that's overwhelming. And again, like, sometimes we do need to have those strong reactions of like, okay, something needs to happen like right here, right now. At the same time, we don't want that to always be our first go-to just in any situation. So a lot of those de-escalation type of strategies, I think, really do play out well, because I always tell the interns I work with and trainees and everything that the biggest and most important part of working with adolescents is authenticity. Some of it is they can just smell inauthenticity from a mile away. I mean, they're
right
just
through you.
aware. Yep, then they will let you know. But also, again, there's a huge power dynamic. First of all, I'm an adult, clearly, and teenager, and there's just power differentials there. I'm an authority figure, whether I want to be one or not. I mean, I am. And I also have a lot of power in the relationship, whether I want to or I don't. I mean, if they do report certain, suicidal ideation, or especially if it's active, I do have power in that sense. And I think just accepting that and participating with it and recognizing it and kind of just calling it like it is, not only helps equalize, but we can really take steps again to incorporate the client back into that collaborative approach, but again, work collaboratively together. And I think that goes a long way with teens. Also, just validating their emotion, allowing them room to be upset, isn't like, well, it's okay, and like immediately trying to problem solve, like, here's why I'll do this, this, and this, so you don't feel that upset about it. Because again, I mean, we do want to make it, easier for them, but also want to make sure we're not reinforcing that it's all on us to manage their emotions. It's all on them to not have that emotional reaction.
Right, like it's wrong to have an emotion.
Right. And just allowing them space to grieve or be upset or be angry at us, and also normalizing it's okay to be angry at me right now. Like I would be angry at me in the situation.
Mm-hmm. Yeah, you can have a reaction. We all do.
Sure.
Yeah.
Absolutely.
Okay. Thank you for sharing that. I think that that's really helpful, especially for folks who are not as familiar with navigating work with adolescents, but even for those that do, just to kind of be mindful of that. And then for maybe some of our listeners who aren't necessarily professional counselors, but are navigating their own lifestyles with adolescents, parents who are needing some of these reminders as well to take this away. So thank you. We know that parenting can be a balancing act, no matter the age, but especially with this age group. And being an adolescent can feel like a balancing act too, because you're leaving, your childhood, trying to figure out identity and things like that. So speaking of the balancing act, right? How do we as professionals, maybe as parents, like navigate understanding like if our teens are engaging in risky behavior, or not? Like, is what my teen is like doing over there good, bad, risky? Somewhere in the middle.
Yeah. And this is another huge parenting dialectical dilemma that comes up that I think requires a lot of psychoeducation and also navigating core mindfulness skills, emotional regulation with parents, and just all those different pieces and parts. And the dialectical dilemma being, in the clinical terms, normalizing pathological behaviors versus pathologizing typical and normative behaviors. Or again, as I say it less clinically, to the parents. We're making light of problematic behaviors versus we're making way too much of typical adolescent behaviors. Because especially in families who have been through crisis, so if a teen has attempted suicide or engaged in some pretty severe self-harm actions or whatever the trauma might be, but those experiences are traumatic. Not just to the adolescent, of course, but also to the parents. There's a lot of feelings of shame, of anxiety, of fear, of guilt that come up, and a lot of complicated emotions. And on one hand, sometimes I think the bar has been changed so much as in, okay, we're not engaging in self-harm, and that's okay. We're doing everything and putting all of our energy to make sure that the self-harm is not occurring. However, other things that build a satisfying life also aren't being taken care of. And we're not going to school and we're getting truancy threats, or we are not showering, eating, whatnot, because I'm afraid of triggering my teen, and then they have self-harm if I try to get them going and get them up and moving. Or on the other hand, or just with it, and again, we're normalizing some of the pathological behaviors versus we're pathologizing some normal developmental behaviors. As in, teens are known for being risk takers. I mean, it's a big part of just being an adolescent. They're known for not always making the best decisions or having good insight as far as long-term consequences. I mean, how long have movies or just media been around talking about teen parties, teen drinking, teens' risky sexual behaviors and such? It's a part of adolescence. And again, we really try to find that balance of we're experimenting with a substance. I mean, not that I'm a lot, advocating for that.
We're not encouraging that kind of behavior, but is it normative, or I don't like the word normal, typical teen behavior versus something that is pathological, right?
Right. Like, are we experimenting with cannabis for the first time at a party versus are we selling cannabis at school, or we're using daily to cope and just navigate and survive with our anxiety? So again, we're trying to find those balances, because especially parents who have been in these traumatic situations, sometimes we see slip-ups, which again, part of being an adolescent, but it results in that huge crisis reaction, which results in the teen pulling away, shutting down secretive type of behaviors, which sets off the red flags with parents, and we really need to get into it, and it creates this whole system and challenge in itself. So again, it's teaching parents how to attend to it. Again, not saying they just let it go, but at the same time, how do we address it without going to the crisis place again?
So how do you determine where's that line? What's the difference?
Yeah. I think some of it is just general psychoeducation. Some of it is what we call in DBT listening to our wise mind. So this is where we are balancing what we call reasonable mind, which is our logic, how A gets to B gets to C, and our emotion mind. So reacting emotionally and reacting authentically with our emotional reactions. And so we're listening to what the logic tells us, as in, this is a history of behaviors, but we're also validating our emotions. We're coming together to participate with that. So sometimes training parents listen to their wise mind judgments. I don't think there's always necessarily a black or white answer of what qualifies which. And again, that's what maintains a dialectical dilemma of But some of that, some research and basic education, again, depending on what the crisis is, whether it's risky sexual behaviors, as in we're having unprotected sex with multiple partners, if it's substance use, again, that's crossing the line of just some general experimentation, where, instead of having just a couple friendship fallouts, as in we're having trouble maintaining any sort of relationships with others. I think really educating parents, where that balance is, sometimes providing them resources, but also really empowering them to listen to their wise mind judgments. And then it kind of connects back to setting those boundaries accordingly. So again, we're not flip-flopping between too permeable versus too rigid.
Okay, good. So, you've mentioned DBT a lot, and in some past episodes we really talked about theoretical orientations becoming a bit like glasses that you wear, like rose-colored glasses, and so being seeing things through DBT colored glasses. I'm wondering if you could describe your experience with wearing DBT colored glasses and what it's been like informing your work and using that with your clients.
Absolutely. Especially with teens, because we have DBT-A, so that stands for Dialectical Behavior Therapy for Adolescents. And there's a whole manual that comes with it. It was created by Rathis and Miller. That's kind of the go-to, and it's based on off of Marsha Linehan's original DBT skills training manual, just adapted for the adolescent population. There's a lot of research out there that indicates DBT is great for adolescents, especially those presenting with depression, suicidal ideation, self-harm concerns. But I would argue it can even be used in different settings. So we have those tertiary settings where, again, we're an IOP versus a secondary versus just general individual counseling. But even those primary, as far as some of that community-based preventative type of care of just general psychoeducation in schools, groups, some of those things, again, that occur more so in the client's meso system. But a lot of the research indicates it's so beneficial as, again, adolescents struggle with emotion regulation. Some of that's just developmentally where they're at in a very normative place to be in. But especially those struggling with specifically dysregulation, as far as, and again, the crises or difficulty identifying what emotion am I feeling, and especially in that core mindfulness type of area, or surviving things. So again, adding all the biosocial factors of living in an environment we perceive as invalidating, but also some of the biological factors of just the development of the teen brain and all the hormones going on, and just, again, like growing into that autonomy and into that adulthood. There's a lot of benefits to that, because these are typically areas that we're all struggling with. And then also so we have the core mindfulness, emotion regulation, interpersonal effectiveness of relationships, and distress tolerance. But a fifth pillar that comes up specifically in DBT-A is what we call walking the middle path. So these are all these dialectical balances that we're always trying to find with the adolescent, but also especially in the system. So their families, school counselors, and a lot of times like getting when appropriate, will appropriately release information on file, school counselors or other individuals that may be a part of the client's life involved, and also helping them navigate these dialectical challenges that come up.
So I love all of what you have to say there, and I think this is so cool. I don't do a lot of work with adolescents, but I have a lot of adolescents in my family, so I'm like, oh yeah, this is great, powerful, good stuff. So I guess, like, how have you used this with adolescents? Like, what kind of diagnoses? Like, how do you see this like working with adolescents? I mean, obviously, I know you do, because it's primarily what you do, but tell us more about like how you see it working with adolescents.
Absolutely. Especially in our intensive outpatient program. So again, that's our higher level of care. And then trainees typically, or interns typically, ask me this: is, well, why would I refer a client to IOP, or what would actually be a good IOP case? And I always say, we got to treat it dialectically. Like, yeah, typically depression, anxiety, and especially in more the severe range, are good diagnostic criteria, especially with insurance coverage purposes. But at the same time, what we really have to assess is impairment and quality of life. So maybe we have anxiety, and it's not necessarily the worst case of anxiety we've ever seen as far as how it's scoring on something like a G87. However, we're not going to school, and we're feeling really socially isolated. And again, the truancy charges are starting to feel a little more real each day, and just everything that comes with it. And that really starts to impair how satisfied we are with our life and such. And so I think that's the biggest criteria regardless of diagnoses. However, typically what most common presenting concerns are, again, like the depression, so especially severe depression, self-harm, suicidal ideation, homicidal ideation. Always want to be careful with that in a group setting, but can be appropriate. I'm always careful to diagnose adolescents, and I'm cautious with borderline personality disorder. And at the same time, that's really when those traits of borderline personality disorder start to emerge, is in that adolescent area. And again, always kind of treating that dialectically, but that also is a pretty common aspect in giving resources to parents to provide that support earlier on and everything, so we can navigate together. But also, again, there's a lot of different types of adaptations for DBT, whether it be adolescents or just in general. Like, I know DBT specifically for eating disorders, or specifically like a DBT-S for substance use. So a lot of different adaptations, but overall the central theme here is just individuals experiencing significant difficulties with emotional dysregulation.
Which can happen a lot for many experiences in a teen's life. Just because of, like you have mentioned already, developmental stuff that's coming up. Yeah. So, big question here. What is it that you think makes it so effective?
Absolutely. And it depends. You can practice DBT. You can use DBT individually. Like, if you are a private practice, or just a private practitioner, like truly working in solo practice, it's appropriate to use some of the DBT skills, because there's a lot of different skills that come with it, like Dear Man, radical acceptance, and there's a lot of research that could be done as far as what that means in context.
Love radical acceptance over here. Love radical acceptance.
I mean, you could definitely incorporate that into just individual counseling sessions. However, DBT in itself is not just a skill here and there. Like, the true DBT is a lot of different pieces and parts. And so again, this isn't typically individuals who need that tertiary level of care, as far as a lot more intensive and higher level of care. So we have the individual counseling to really process things, but then the skills training group, so how it exists in our IOP to learn the skills, which, great, super fun, but I really think the healing part that comes through that is the group therapy. Now, I'm a big advocate, I know I'm biased, but especially with adolescents, what are they going through? It's the invisible audience phenomenon, as in, no one understands what I feel, and I am the only person who experiences this, and everyone is judging and thinking I'm weird for having experienced this. That's a big part of adolescence, let alone an adolescent struggling with depression or such who feels, those symptoms of worthlessness, hopelessness, isolation, alienation, a lot of the aspects that come up there. And so sometimes just being in a group setting and being like, wait, other people struggle and are also going through it, it just really normalizes those emotions. And I think that's the really healing part, but also giving them space and also teaching and themselves how to give themselves the room to feel this way, especially in a social setting. Because again, the big part of DBT is a biosocial theory, is in we perceive our environment as invalidating. So when we can foster an environment that feels safe to talk about our emotions for a couple hours a week, that's what starts to allow us to externalize it outside of the therapy space. And again, that can definitely be accomplished in individual counseling. Although I will say, they typically listen to what their peers have to say, and that's a lot more important sometimes than what I do.
That group can be so powerful. Like it's a different, it takes on its own, its own personality. So we're called Ohio Counseling Conversations, and I think that this is an important question. So what important conversations do you think that we as professionals or parents should be having with teens about teens?
Absolutely. Education is something that's very important to me, large part of my identity and value system. I absolutely love to present at conferences and such, typically about DBT, since that's my niche. However, I've noticed some of the most feedback I get when presenting about this area at conferences or just some of the most attended type of topics I teach about is what we call therapy interfering behaviors. So this is an aspect of DBT, and all of TIB, or therapy interfering behavior, we call it TIBs, mean is just any behavior that prevents the client from meeting their treatment goals. And that's typically what I talk to most about with counselors, with teens themselves, reflect on for myself personally, or parents. As in, these can look a lot of different ways. As in, it could be, I forgot about my therapy appointment today. Or it can be, I'm so burned out because I've had such a chaotic day that I'm having a hard time being present. Or the parents being, I don't know, it's your job to fix the teen. I'm just here to have you deal with this type of attitude, the fix my child attitude. And again, really important to present this in a way to adolescents as far as the most non-judgmental way possible. And a lot of times I'll do that through a very non-threatening example of, so let's say a client, missed an appointment because they didn't have a car that day. And if I sit here and say, well, you should have been here on time, first of all, that's not a social justice approach. That's not looking at what boundaries, and whether it be financial concerns that may have come up, or just, again, present based on where we're coming from. We may not be sleeping enough to maintain a schedule, and that really does further help us understand as far as how much these symptoms can be impairing the quality of life that the teen is experiencing. So that's the acceptance part. But the change part is if I say, yeah, like it's fine, don't worry about it, I get it, we all miss sessions. The problem is that they can't meet their treatment goals if they can't get to treatment. And so this is the acceptance and change, and that's the really important part to incorporate, because I think a lot of times where counselors struggle the most is, how do I navigate cases where I feel like there's a lot going on and interventions I'm trying aren't working? As in, again, clients are not paying for sessions, they're missing sessions repeatedly, we're putting in all these different safety plans or whatnot at the school setting, and crises are still happening, and I feel like we're trying this, and this, or they're still not coming to school, and we're pretty burned out. And I think, again, like that's a hard place to be at. And this is a collaborative approach, is where if we, again, present it to teens or parents, or in the most non-judgmental way possible, and really with that unconditional positive regard, we can leave a space to explore that as far as, what are the obstacles? Okay, we didn't have a car today. How do we navigate that together? So maybe we need to look at some bus routes, or maybe I need to get the client connected to some community resources as far as financial ability, or being able to afford things, or kind of going from there. Like, again, if we're looking at hierarchy of needs, maybe we're starting too high and need to go down to some more basics. But when we present it in a very authentic and non-judgmental way to teens, it kind of makes sense that it gives them a space to really truly reflect as far as what is happening, but also advocate for themselves as in, here's what my needs are. And I also leave them room to explore that as far as, again, like, it's not just a one-way relationship. We as counselors contribute obstacles too, as far as things we're doing that interfere with the client getting to their goals, whether it's we're maintaining boundaries to the point where we're not being flexible, or we're afraid of setting boundaries because I don't want to hurt their feelings. Or again, the client escalates and it becomes the entire pressure on us to de-escalate them throughout the session. Which again, I mean, we do teach strategies, but when the entire pressure is on us to de-escalate, that may not always be the healthiest dynamic. And so it's having that open and honest conversation is how can we all collaboratively work together to address these obstacles, remove them or empower them, or really teach them how to advocate for themselves to navigate and come to that goal collaboratively together. So that's the big one I advocate on.
I love it. And I think that that's really important in terms of a lot of our multicultural social justice counseling competencies. I think that that is really powerful to say we're promoting access and we're promoting the collaboration and we're having a conversation about it, right? That Ohio counseling conversations, right? Bringing it back to conversation. And I think just to piggyback off of that, are there conversations then you think that counselors should be having in regards to your favored population as well?
Absolutely. I think a lot of it has to do with accessibility for teens. We've been talking about this recently, but it's first of all hard work. I mean, counseling is in general, I think, can advocate, but maybe this is my bias since I've always been an adolescent counselor, but I know I've often had, I'm a teen counselor and I get a lot of, oh dear, type of reactions from other clinicians, which, I mean, if not their population, that's okay. But a hard part that comes with it is, again, you are not just treating the teen, you're treating the entire system the teen resides in. And I mean, I think there could be an argument that occurs with adults too. But again, especially with teens where they have autonomy, but they don't necessarily always they don't have the legal aspects to make the independent choices. Like if an adult is having a hard time at work, they can quit their job. I mean, not saying there's not consequences to that, but they have the right to. Where teens, if you just stop going to school and stop showing up, things escalate legally pretty quickly for them if we're not, again, doing some of those requirements of them. And that's a hard aspect as far as, again, like this means that a lot of time when working with teens goes to not just those individual counseling sessions, it goes to tracking down parents to have conversations with them and tracking down school counselors or pediatricians or whatever it might be. Because again, there's a lot of different aspects, especially in those higher intensity cases that also need attended to. And the hard part for that is that typically isn't financially compensated as far as all that different time that we are investing. And so I think it is this type of concern, especially with everything where it's a lot of, emotional labor, but it's also a lot of labor that necessarily isn't compensated. And how do we advocate for ourselves as a profession to make sure that we are compensated for our work and whatnot? Again, I know that's a much bigger conversation to always have time to get into as far as just, podcasts and everything, but it's something I think needs...
It's relevant though, yeah. and I think at least opens the door and gives some insight into those who may consider this type of work or who at least may be exposed to it in some way, shape, or form, so that they're aware. I think part of what we have created this podcast for is to create that awareness. And so I thank you for sharing that. I think it's very critical that we expose and teach here. That's what we're here to disseminate information and give that information so people can learn and understand that this system of working with adolescents does have a lot more touch points than maybe a lot of people think, because of these clients being still children, by law, right? And so there have to, by law, be more people involved, and oftentimes it does require collaboration within multiple systems as a result of that. So I think that that's a really important point that we have to consider, and then we're going to have to operate within those levels if we engage in that work. So I think it's not lost on me, and I hope it's not lost on the listeners, and that people are encouraged by what you've shared today, and that the exciting work that can happen with DBT with adolescents, and that there's a lot of exciting work that can be happening in work with adolescents. So thank you so much for joining us today, Hayle. Is there any parting words, any last advice or information you'd like to share before we wrap it up?
Absolutely. Just the last aspect is, again, social justice in that bigger picture is a large part of identity and everything. And I think a lot of it is, again, it's great to, kind of furthering what we've already discussed, it's great to work on that micro level and to, individually have clients. But at the same time, I really do believe in advocating as far as navigating the meso system and the macro system. And I hear so often from parents, I think this is a general problem in counseling, but I've called so many places and no one's gotten back to me, or there's a wait list of a couple months or such, but especially true for adolescents. And I think a lot of that comes down to just general obstacles we face as counselors. So I do want to encourage listeners as far as how do we solve that problem, because again, it's great to work on an individual level, but this is a continuous large problem as far as the bigger picture. Maybe there's some efforts that we could do to further navigate and be an advocate there. That's my parting words.
Start having more conversations outside of this podcast is the point. Yeah. Okay. Well, thank you so much, Hayle. We're so happy that you joined us today, and we hope that you'll continue joining us here on Ohio Counseling Conversations, and we'll talk to you all soon.
My pleasure. Thank you for having me.
If you enjoyed this episode, please make sure to follow us so you can stay up to date with Ohio Counseling Conversations online and wherever you listen to podcasts. If you're a counselor in Ohio and would like to get involved as a part of production or as a guest, or know someone who might be interested, you can email us at ohiocounselingconversations@gmail.com. Thank you for listening.
This podcast is brought to you by the Ohio Counseling Association's Media, Public Relations, and Membership Committee and its podcast subcommittee. This episode was executive produced by Hayle Fisher and Marisa Cargill. Research and fact-checking by Kailey Bradley. Editing by Leah Wood. Original music by Elijah Sotoru Wood. Special thanks to Stacy Tasmer, Sherdine Simpson, Dohi Kimopel, Alma Moore, Amy Barcelo, and Chase Morgan-Swaney. Views, beliefs, or references mentioned in this episode do not constitute an endorsement or recommendation by the Ohio Counseling Association. The views expressed by guests are their own, and their appearance on the podcast does not imply an endorsement of them or any entity they represent. Views and opinions expressed by guests do not necessarily reflect the view of the Ohio Counseling Association or any of its officials. Thank you.